The following podcast is part of a certified educational activity titled Advancing Therapeutic Control in Desmoid Tumors, Expert Guidance on Modern Diagnostic and Treatment Practices with Gamma Secretase Inhibitors. Access the entire activity and complete the post-test at peerview.com/QXP860. Downloadable slides are also available.
Hello, and welcome to this educational program, Advanced Therapeutic Control in Desmoid Tumors. My name is Mrinal Gounder. I'm a medical oncologist at Memorial Sloan Kettering in New York, and today I will be discussing modern diagnostic and treatment practices with gamma secretase inhibitors to optimize patient outcomes. So let's begin with our educational goals for today. In this program, we have 3 modules. In the first module, I will be going over the epidemiology, natural history, clinical presentations of desmoid tumors. In module 2, we will talk about therapeutic strategies, how to diagnose this correctly, and the different ways to approach desmoid tumors, including updates on regulatory approvals, practice guidelines, and patient disease-specific factors. And in the last module, I will go over several case presentations to solidify some of the main lessons learned in today's session. So first, let's begin with an overview of desmoid tumors. Basically, some of the gaps and challenges in diagnosis and treatment of desmoid tumors. First, it's very important for us to understand that desmoid tumors are rare. They have a variable presentation, clinical course, and outcomes. These are unlike many of our usual paradigm of how we think about tumors and cancers. There's also initial misdiagnosis with this tumor, simply because of their rarity and some other histological mimics, and I will certainly talk about that in the coming slides. There are many effective, safe, and regulatory approved systemic therapies that have come up on in the recent last few years. And I'll certainly touch upon that. And very recently, there's been an update in the ICD-10 diagnosis code to properly identify desmoid tumors, not only for billing, but also to further research in this space. So as I mentioned before, these are rare tumors. So the incidence of desmoid tumors is somewhere around 3 per million, or as it's noted here on this slide, 0.2 to 0.4 per 100,000 per year, which means in the United States, there will be approximately 1,000 new patients diagnosed with desmoid tumors annually. In Europe, this is about 3,000. In Canada, it's about 140, which is very reflective of the population sizes here. What type of tumors are these? So these are tumors that arise in fibroblasts or myofibroblasts. And the cause of these tumors, for the most part, are thought to be sporadic. The sporadic mutation is one in beta-catenin. Beta-catenin is encoded by a gene whose lettering is CTNBB1. Again, that's CTNBB1. So if you get a next-generation sequencing or an RT-PCR, it will not say beta-catenin, it will say CTNBB1, and that's important to know. And most of the desmoid tumors arise from beta-catenin sporadic mutations. However, 5 to 10% of desmoid tumor fibromatosis is associated with FAP or Gardner syndrome, and this is very important to know, as the implications for patients with known APC mutations as germline or those who have known FAP, the desmoid tumor could be a canary in the coal mine and could say something else about that patient and what else is going on. So family history is very important, and in this context, genetic testing or colonoscopy in the right patient is also important. So as I mentioned before, 85% of cases harbor somatic mutation in CTNBB1 gene, which codes the beta-catenin protein, which is found on chromosome 3. And this is a schematic plot, but essentially what we're seeing here is that these mutations can occur either in beta-catenin, noted here in blue, right in the center here, or in APC. Either one of these mutations in APC or beta-catenin can result in constitutive activation of beta-catenin, which then migrates into the nucleus and turns on the transcriptional factors that leads to growth of desmoid tumors. One of the important things about desmoid tumors is that they generally do not metastasize. These are localized, locally aggressive connective tissue tumors. On some occasions, you can certainly find multifocal desmoid. We think of this as several desmoid tumors occurring in the same limb or in the same area, but discrete and independent of each other. We do not believe that these are metastatic tumors. So in that sense, desmoid tumors are locally aggressive connective tissue tumors. So how are desmoid tumors currently diagnosed? The vast majority of desmoid tumors are diagnosed by pathologists using basic imaging and histopathological assessment confirmed on a biopsy. One key thing that one must test for and look for is nuclear beta-catenin. Again, nuclear beta-catenin staining by IHC is very important in these situations. As I mentioned before, beta-catenin is the most common mutation found in these tumors at the DNA level, but so is APC. And in the right clinical context, in a case-by-case series, it's important to make sure your patient does not have an APC mutation that may lead to FAP. And careful family history and even a colonoscopy in the right patient is recommended by NCCN guidelines. If you do a biopsy and the patient has a known, which demonstrates that there is a somatic beta-catenin mutation, that is quite confirmatory that you're on the right track. But if the patient has other signs and symptoms of family history that are suspicious for significant amount of polyps, or there is a risk of colon cancer, one cannot just rely on that. Of course, you could do a germline testing and make sure that there is no APC mutation, or in the appropriate patient, refer to gastroenterology for a colonoscopy. So desmoid tumors can really occur anywhere from head to toe, and they can occur in any age group. So we see patients who are as young as 1 or 2 years of age, and those who are even in their 90s. But the peak incidence of this disease is typically in the 20s and 30s, but there's a wide distribution. And these tumors can occur anywhere from head to toe. But the most common locations are as follows. These are generally extremities. So as you can see here, lower extremity and upper extremity are almost 1/3 of all cases. Abdominal wall. So abdominal wall is typically in the rectus sheath. So this can be about 25%. And 5% can be deeper in the abdomen, which are known as intra-abdominal. These are much higher risk, and there's a higher risk of bowel perforation or hydronephrosis secondary to urethral compression in the intra-abdominal or the pelvic girdle tumors. Scapula is another area, almost 20%, and then really anything else. This could be head and neck. It could be paraspinal. There is a slight preponderance, I would say about 60% of female preponderance, depending on the data set that we look at. So in younger women and men, you will notice that desmoid tumors are much more common. Desmoid tumors, as I mentioned before, can be multifocal. Most of the time, they are a single primary disease that transect or invade into other fascia and fascial planes, but they do not metastasize. But we do find multifocal desmoid tumors. As you can see here you can see a desmoid tumor in the lower extremity of this patient, and you can also see smaller enhancements in other locations. And here again, you see a multifocal desmoid. So how do we treat these tumors? Historically, these tumors have always been surgically resected. And I want to emphasize on the word historically. Historically, these have been surgically resected, as most sarcomas or most of these tumors have been done. But over the last 10 years, data from the United States as well in Europe, particularly in Europe, have shown that even after an excellent surgery with an R0 resection, these tumors have a very high risk of recurrence. There are nomograms, particularly from Memorial Sloan Kettering, where these are publicly available nomograms that demonstrate that there are certain high-risk prognostic features, young age, female, certain locations, with a good surgical resection can still result in very high recurrence. So the consensus guidelines currently from the United States, Europe, and other regions have come together and said that surgery may not be in the best interest of all patients with desmoid tumors, and a very careful case-by-case presentation of these patients need to be done and determine whether surgery is still acceptable or not. But for the most part, surgeries has been deprioritized as an initial way to treat these tumors, given the very high recurrence rate, even with an excellent surgery. So again, just to emphasize, surgery is no longer the primary and only curative treatment for localized disease, as unnecessary surgery is harmful to patients. Sometimes the surgery and the morbidities associated with surgery may be worse than the disease-related morbidity. So that's something to keep in mind, and this is evolving, especially in the last several years. So how do we treat these tumors? So here are some of the current and emerging treatment options for desmoid tumors. The first thing is active surveillance or a wait-and-watch approach. Wait-and-watch has been increasingly favored in the last, I would say, 5 to 7 years. And this is again based on data from Europe as well as the United States, which shows that nearly 20 to 30% of desmoid tumors, again, that's 20 to 30% of desmoid tumors, can have a spontaneous regression with just watching. Does that mean active surveillance is the right approach for every patient? No. In patients where the tumors is rapidly progressing or is in a critical location such as the intra-abdominal or head or neck or paraspinal, or there is a threat of visceral organ involvement, or if it's pressing on nerves or blood vessels or other areas, which is causing significant symptoms to the patient, then in those situations, active surveillance is not recommended, and it's important to think about other modalities. But in patients where the disease is small, is in a favorable location, and asymptomatic, active surveillance is a reasonable approach where we would repeat scans every 3 to 4 months with either CT or MRI to see how this tumor is progressing or spontaneously regressing. What are the other options here? Chemotherapy, and I will talk about this in the coming few slides. Tyrosine kinase inhibitors, particularly sorafenib, and the more recently approved gamma secretase inhibitor, nirogacestat. And in rare cases, in the appropriate multi-specialized discussions, surgery may be appropriate, and that's something worth discussing about. Lastly, local therapies are also gaining favor. This would be cryoablation or radiofrequency ablation, and in some highly specialized centers, high-frequency ultrasound. But with local therapy, it's really critical that this be done by an interventional radiologist who has expertise in treating desmoid tumors. Sometimes local therapies done in the wrong hands can again make the situation worse for the desmoid tumor patient. So this is again very important. And for any kind of a reference, a JAMA Oncology paper was just published by Bernd Kasper et al., along with the Desmoid Tumor Working Group. This is a multinational consensus guidelines that was just published in 2024. What else is new in desmoid tumors? We have a new ICD-10 code. There were several different codes where desmoid tumors were lumped into those. But unfortunately, that did not allow for proper billing, nor did it allow for proper research in databases. So the new ICD-10 desmoid tumor code is D48.11. But it doesn't just stop there. it's really important to specify the location of the desmoid tumor. And as you can see here, there are 8 specific areas where you can further use the right location. Again, this is essential for billing, but very, very essential for future research in these rare tumors. So taking a few extra seconds to put in these right billing code can help move this space in the long way. One billing that is discouraged is using D48.119, which is essentially says desmoid tumor of unspecified site. This should ideally not be used if we can help it. So now we're going to shift to Module 2. We're going to talk about translating these clinical updates with modern systemic strategies in desmoid tumors. First thing, historically, desmoid tumors used to be treated with hormonal agents such as tamoxifen, but this is no longer being used. And the rationale for this is that there is desmoid tumors associated with pregnancy, and as a consequence of that, people associated this with levels of estrogen and treated with tamoxifen. But increasingly data, as well as a consensus guideline, says that tamoxifen and other hormonal agents are really not helpful for treatment of desmoid tumors. Historically, NSAIDs have also been used to actually treat desmoid tumors, but these are, again, many research as well as the consensus guidelines do not support the use of hormonal agents or non-steroidal inflammatory agents for the treatment of desmoid. Can we use NSAIDs for symptom management? Yes, of course, but there are also newer agents which may do an excellent job in terms of pain control as well as functional improvement with these newer agents. Next, cytotoxic chemotherapies. Historically and currently, we use cytotoxic chemotherapies. There is good amount of data on the use of methotrexate and vinblastine, or methotrexate and vinorelbine, or vinorelbine by itself. We also use Doxil, or pegylated liposomal doxorubicin, which has an excellent tolerability profile, and it's given once a month with a fixed number of doses, again with excellent outcomes. And there is papers on this as well. And of course, the anthracycline-based regimens, but those are a little bit more toxic and may be reserved when all other therapies are exhausted or if other therapies are intolerable. Again, when do we use this? For any desmoid tumors, we need to use it when it is rapidly growing or symptomatic or life-threatening. In those situations, not just chemotherapy, but any systemic therapy or intervention should be reserved when the patients really need it. In other situations, when things are quiescent, wait and watch approach is perfectly acceptable. And again, remember, most of these trials, they do not have randomized data. They're all single-arm studies where overall response rates or PFS have been reported, and some of the references are noted below. Next, switching gears to tyrosine kinase inhibitors. So tyrosine kinase inhibitors have been used. We've looked at imatinib, but increasingly the data shows that imatinib is not the best drug when it comes to a tyrosine kinase inhibitor in desmoid tumors. The drugs that appear to be far more active are sorafenib, and there is some data with pazopanib as well. But we have phase 3 randomized data with sorafenib. And the dose of sorafenib is very important in treating desmoid tumors. Unlike renal cell or hepatocellular carcinoma, where 800 milligrams is utilized, for sorafenib, you can get away with 400 milligrams, which is what was used in this clinical trial, or even lower doses, 200 milligrams daily, or in some patients who are intolerable, even 200 milligrams of sorafenib every other day. So really quality of life and paying close attention to the patient's side effects are very essential in the management of desmoid tumors with tyrosine kinase inhibitors, particularly sorafenib. And here's the phase 3 randomized study of sorafenib versus placebo. This was published in the New England Journal of Medicine. And as you can see here, there is a a dramatic improvement, almost a 7-fold improvement of sorafenib over placebo in these patients. And this had a hazard ratio of 0.13, with sorafenib having a significantly improved median progression-free survival compared to placebo. What about response rates? And here's a waterfall plot that you will not see in any other oncological situations, or these are very rarely seen. And on the left-hand side here in orange, you will see that the placebo also has response rates. This again reiterates the importance of active surveillance in select patients. And with sorafenib, you see significantly more response rates, and the durability of responses in sorafenib are also significantly higher than placebo. So again, patient selection is very essential in treating desmoid tumors. So next, we're going to shift gears and talk about gamma secretase inhibitors. So these are a whole new class of drugs. They've been in development for nearly 2 or 3 decades. First in Alzheimer's disease, where it did not work, subsequently switched to other more aggressive malignancies where it did not work, and subsequently they were abandoned, and very recently they were resurrected. This gamma secretase class of enzyme inhibitors have been resurrected in desmoid tumors and other rare indications. There are 2 new classes that are currently being developed. There is one drug called nirogacestat. I'm going to go into the details of the clinical trial and the FDA approval, which happened in November of 2023. And there is another agent, also gamma secretase inhibitor, AL102, which is currently in phase 3 clinical trial, and the results are awaited. So how do these work? First is that gamma secretase inhibitors essentially inhibit the activation of the gamma secretase enzymes. Gamma secretase enzymes are found in many different cells, playing vastly different roles and functions. We think there are hundreds of different types of gamma secretase enzymes, and the cleavage of a gamma secretase enzyme results in downstream activation of many different cell signaling pathways, depending on the cellular context. Here, it is thought that desmoid tumors have a dependency on the Wnt, or the Notch signaling pathway, and the activation of the gamma secretase enzyme results in the Notch intracellular domain, here designated as NICD, which then subsequently goes on to activate beta-catenin. And the nirogacestat, or AL102, are inhibitors of the gamma secretase enzyme and subsequently prevent downstream activation of the cell signaling pathway. So let's talk about this phase 3 clinical trial of gamma secretase enzyme inhibitor nirogacestat versus placebo that has been completed and resulted in the first FDA approval of nirogacestat for desmoid tumors. So this is a global, randomized, double-blind, placebo-controlled phase 3 clinical trial with crossover evaluating efficacy, safety, and tolerability of nirogacestat versus placebo in adult patients with progressing desmoid tumors. 142 patients were randomized across 37 sites in North America and Europe, and patients were randomized in a 1:1 fashion to nirogacestat 150 milligrams given twice daily, continuously, with each cycle being 28 days, versus placebo. And at the time of radiographic progression in placebo, if there is a RECIST progression of 20%, patients can then enter into an open label nirogacestat or crossover, essentially. And here are the demographics. These are fairly matched between nirogacestat and placebo. And as you can see here is that the tumor location was either intra-abdominal in about a quarter of the patients and extra-abdominal in rest of the patients. A quarter of the patients in this study were treatment naive, and the remaining majority of the patients had previously failed treatment or had recurrent disease after an initial therapy. And as you can see here, the number of lines of any prior therapy was 2, with a range of 0 to 14. And in the placebo arm, the number of lines of any prior therapy was 2, with a range of 0 to 19. And as you can see here, patients have had prior systemic therapies, radiation therapy, and nearly half of the patients had prior surgeries. And 40% of patients, 39% on nirogacestat arm and 43% on placebo arm, had uncontrolled pain at the time of entry into this study. The primary endpoint of this study was progression-free survival. And again, we see here a significantly reduced risk of disease progression on those patients who are treated with nirogacestat versus placebo. And again, we have a hazard ratio of 0.29, again demonstrating a significant improvement in the median progression-free survival of patients who have been treated with nirogacestat. Do all patients benefit? Yes. So this shows across pre-specified subgroups, patients with either beta-catenin mutation or APC mutation. As I mentioned before, those associated with FAP, they both benefit with nirogacestat. And whether they were previously treated with chemotherapy or TKI, it did not matter. Whether they had previous surgery, whether it was single location or multifocal, these drugs, nirogacestat, works in all these pre-specified situations. What about the long-term use of these drugs? So here is an update from the Connective Tissue Oncology Society meeting, which is the major international sarcoma meeting from 2024. And this again showed that in a subgroup of patients who were treated for more than 2 years, almost up to 4 years, there were additional responses, 3 PRs and 3 new CRs. Again, in a subset of patients, longer use of the drug may be helpful, but careful patient selection is very essential in this arm. Again, we're seeing longer-term use of nirogacestat was associated with durable tumor size reductions and evidence of deepening responses. Here you see a very nice response in the nirogacestat arm, as you can see with this spider plot. These are durable diseases as well. And in the green, what you're seeing are patients who end up with a complete response, and in the blue are those patients who have a partial response. What about symptom improvement? So as I mentioned before, the overall survival of these patients is usually intact. The death from desmoid tumors is exceedingly low, typically related to intra-abdominal disease. Those have a very high risk. But in general, overall survival is not the best endpoint for clinical trials or in general for patients with desmoid tumors. So they have improved progression-free survival, but does it help improve their symptoms? And the answer is yes. And what you see here is that those patients who are treated with nirogacestat on the DeFi study have a significant improvement in their pain, and also using the Goddess instrument for looking at both the symptom as well as physical functioning. You see a quick improvement in the total symptom score, as well as a rapid improvement in the physical functioning score of patients who are treated with nirogacestat. And again, we see similarly that in the post-hoc analysis, that patients with APC mutant desmoid tumors did equally well with the use of nirogacestat. So whether people have APC mutations, FAP associated, or sporadic beta-catenin, the benefit of nirogacestat is improved over placebo in all these patients. Lastly, a quick update from the most recent study is that patients with poor prognostic factors, and these are patients generally thought to have very large tumors, young age, lesser than 30 years of age, and specific types of beta-catenin gene mutations, as well as those with pain, also had consistent improvements in response rates, PFS, as well as patient-reported outcomes. So overall, these drugs such as nirogacestat are helpful in a variety and in different subsets of patients. Going back to the blinded review, as I mentioned before, complete responses were seen in 7% of patients with nirogacestat in the DeFi study and no patients on the placebo arm, although partial responses were seen in 8% of patients with placebo, as we would expect with spontaneous regressions in these tumors, as well as 34% of patients on nirogacestat had a partial response, and many other patients had stable disease. And remember, in this disease, in this study, patients with progressing desmoid tumors were enrolled. How long does it take for patients to benefit? It takes approximately 5.6 months on the DeFi study for patients to start responding and having shrinkage with nirogacestat. And spontaneously, this took almost double the time at 11.1 months with quite a wide range. The other thing to remember here, is that the range can also be somewhere from 2.6 months to 19.4 months. In other words, you can have delayed responses with nirogacestat or even other TKIs and chemotherapies. So you should definitely continue to watch out for that. And again, looking at the brief pain inventory, worst pain intensity, what we see here is that those patients who are on drug have improvement in their pain, they have improvement in their total symptom score, as well as in their total physical functioning score measured by various different instruments. How is nirogacestat tolerated? And we will dive into this deeper, not only in this section, but also in Module 3. So first thing to remember is that the drug is approved at 150 milligrams twice daily. But in the DeFi study, we saw that nearly 42% of patients required dose reductions due to adverse events. And 20% of patients discontinued nirogacestat for adverse events. What are these adverse events? Most common adverse events are GI, such as diarrhea, nausea, fatigue, hypophosphatemia. And the hypophosphatemia is typically from GI loss. We also see rash, a maculopapular rash, headaches, and stomatitis. We will get into each of this in detail in Module 3 and some ways to overcome and manage this. One of the unexpected side effects from nirogacestat on the DeFi study was ovarian toxicity. And since these are young patients being evaluated for the first time, we recognize that women who are being treated with nirogacestat can have ovarian toxicity. What does that mean? It typically means that there is decrease in the endocrine female reproductive hormone levels, as well as clinical manifestation, which means cessation of their period. So this ovarian toxicity in the DeFi study, we noticed that about 41% of patients, when they first encountered this, they discontinued nirogacestat. All of the patients who discontinued nirogacestat as part of the DeFi study recovered from their ovarian toxicity. Interestingly, patients who chose to remain on the study and still had ovarian toxicity, 9 out of 14 of those patients, which is 64% of the patients, their ovarian toxicities resolved while they were still on drug. And the other patients have their unresolved at this time. And there was a few patients who were lost to follow-up. The median time to onset of ovarian toxicity is about 8.9 weeks, which is about 2.5 months. And the median duration of ovarian toxicity is 21 weeks. But typically, as long as women are on this drug, we will expect them to have some sort of ovarian toxicity. And usually if they come off the drug, we have fine resolution. But it's important to remember that this is a small data set, and we really need to have greater numbers to fully understand ovarian toxicity. So in my practice, I refer patients to fertility preservation and egg retrieval in those women who wish to have children or have fertility as an option in the future who are considering to start on nirogacestat. Next, we're going to stop from nirogacestat and shift to this newer drug, called AL102. I mentioned to you before that this is being developed by another company, and this is being evaluated both in phase 2 with a seamless transition to phase 3. Both the phase 2 and the phase 3 are fully accrued, and the events are being matured, and we will know this data in the near future. So in this study called Ringside Phase 2-3 trial, in the phase 2 section, the purpose of this was to evaluate different doses as well as schedules. And the final winner of the dose and schedule was a continuous dosing of AL102. What do we see in phase 2 with this gamma secretase inhibitor? Again, we see impressive responses in volume as well as in resist. And we also see change in the MRI-T2 signal. What is MRI-T2 signal? MRI-T2 signal is a proxy to look at tumor response, where these tumors can shift from a highly cellular tumor to a collagenous mass. And what you see here, for example, is here in participant 11, you see a white area with some areas of darkness. And on treatment with AL102, this area becomes more and more dark, which signifies transition from a cellular to a collagenous tumor. And you see this again here in participant 2, a T2 bright signal here transforms into a T2 low signal, which demonstrates that this is a treatment response. And that's what we're seeing here with the changes in MRI T2 signal. Okay, so next we are on to the last module, module 3, where we'll be establishing strategies for effective integration of systemic therapies in desmoid tumors with varying patient and disease-specific features. First case is a man with a progressing desmoid tumor. So as you can see here, this is a 45-year-old man proceeded to surgery at an outside facility 2 months after presentation. And the pathology demonstrated 2 masses consistent with desmoid tumors. And you will see here on the screen that there is a paraspinal mass over here. This, unfortunately, rapidly recurs in his flank, and it continues to grow over 6 months. And the patient had been started by Sulindac by his treating physician. Unfortunately, as I mentioned before, NSAIDs such as Sulindac do not help with the treatment of desmoid tumors. They can certainly help with some symptoms, but they are not the best way to treat the desmoid tumor or the underlying problem. And over the course of the next 10 months, this mass continues to enlarge and is now nearly 8 centimeters in size in the paraspinal area, as you can see here. This patient subsequently relocated and was seen in our clinic. He noted awareness of this mass when he sat back in a chair. He denied any discomfort. He denied pain. He denied having any issues with his range of motions or his daily living. As we continue to observe, even though the tumor progressed, even though it's in the paraspinal area but not impinging on any nerves, we continued to watch. And what we noticed is that over the course of the next 4 months, there was a stabilization of this disease. And 9 months later, this had significantly decreased nearly to 2 centimeters or so. So here's an excellent example of the use of active surveillance. And again, I want to stress, active surveillance or watch and wait is not appropriate for every patient with desmoid tumor. It should be reserved for patients with tumors that are stable, not rapidly progressing, and not in a critical location, and most importantly, not having any symptoms. If you meet these 3 criteria, active surveillance with watch and wait is a very appropriate strategy. And I mentioned this to you before. In the phase 3 sorafenib versus placebo clinical trial, we see 18% of patients on placebo have a spontaneous regression. And we see this again in the nirogacestat study, in the DeFi study, where the overall response rates in the placebo arm in patients with progressive disease in the last 12 months was 8%. So this is something to keep aware of. You may ask a question, well, if this patient is progressing, why not treat them at that point? And again, it really depends on the location, it depends on the size, and it depends on the symptoms. So this patient was asymptomatic for the most part and was in a fairly favorable location. And here you look at the Italian prospective observational data. And what you notice here is a waterfall plot. On the far right-hand side, you see patients who have a tumor regression right as they enter this prospective study during a prospective study. There are other patients, if you go to the left side, you will see these lines go above 0%, showing that there is growth. And then you also see in these light blue areas below 0 line. What does that mean? What that means is that patients who were entered this clinical trial initially had progression, but as they were watched, they subsequently had regression. And that shows that there was a 31% spontaneous regression after initial progression, and 25% of patients had initial spontaneous regression. This is, of course, a carefully selected patient population and may not mimic the real-world scenarios. Again, active surveillance is important, but to do so in a carefully thought-out manner. So we've discussed this patient. We had also screened this patient for FAP. You could do this by either testing his blood, making sure that there is no APC mutation, but this patient chose to undergo colonoscopy as he was 45 years old, and a routine colonoscopy was recommended in any case. So we've discussed these things. Next, we're going to go to case 2. Case 2 is a 38-year-old woman with a large aggressive desmoid tumor. She has a large growing desmoid tumor who previously had attempted to do liposomal doxorubicin, but had an anaphylactic reaction and could not be rechallenged, and then tried sorafenib, ended up with a grade 3 rash and fatigue, and found it intolerable despite dose reductions. At this point, she went on to receive nirogacestat at 150 milligrams twice daily for this large tumor. Her treatment was complicated by skin rash, which is actually a hidradenitis suppurativa, which required dose reduction to 100 milligrams twice daily. She remained on this treatment for nearly 3 years on the DeFi study and had a dramatic reduction in size, nearly minus 80%, and a complete collagenization of this desmoid tumor. Let me give you an example here. On the left side is in May of 2020, you see this large growing desmoid tumor that is bright on T2, and you see that it is cellular and active. And on the right-hand side, you see a desmoid tumor that, one, has dramatically shrunk by almost 80%, but has also on MRI T2 signal, has shifted a signal to become a lot more collagenous. She had what's known as hidradenitis suppurativa. What is this? So this is directly caused by the gamma secretase inhibitor, and it is implicated in the pathogenesis of hidradenitis suppurativa. Our practice is to refer them to dermatology, where there are many different options here, including clindamycin topical gel, oral doxycycline or minocycline, or cefadroxil, clindamycin, and sometimes one may even need to do surgical procedure to lance these tumors, as they can be very painful. While this is going on, our recommendation is to hold nirogacestat and consider dose reduction based on the severity of the symptoms. A second side effect that is seen in a subset of patients with gamma secretase therapy is a nasal congestion. So patients report that they have a URI-like symptom with postnasal drip and sometimes with cough, and it feels like having a cold throughout the year as long as they are on this drug. We don't know the full mechanism of action of why this happens, There are really no proven or effective treatments to alleviate symptoms. You can certainly try nasal steroids or anti-allergy and inflammatory nasal rinses. Again, holding the drug, or definitely consider dose reduction to help decrease these toxicities. Generally, we notice that when patients are educated about this and they're aware this could happen, that certainly helps them deal with this therapy. What about the GI side effects? This is one of the most common side effects is diarrhea. So the mechanism of action of diarrhea or GI side effects with gamma secretase is directly implicated in their pathogenesis by increased intestinal goblet cells. So these intestinal goblet cells can secrete more mucus, and this results in diarrhea. So you can certainly try antidiarrheals such as loperamide and other modalities. In general, patients who have a lot of diarrhea, it's important to check for phosphorus, making sure their serum phosphate levels are okay. And if it's low, so you can certainly replete it. And one way to deal with GI side effects is, of course, to hold the drug and let the intestines settle. And if necessary, re-challenge with the same dose or dose reduce depending on the severity of symptoms. And occasionally in these situations, also an intermittent dosing is something that people are considering in the real world, although that was technically not performed in the DeFi clinical trial. And we already talked about the ovarian toxicity, especially in women of childbearing potential. One can get baseline anti-Mullerian hormones, FSH, LH, and estradiol, and then, of course, correlate with clinical manifestations. It's important to know in the DeFi study, although the sample size was low, that 78% of women had resolution of symptoms and hormone levels after drug cessation, and for some patients, even while they remained on drug. But it's very important to discuss fertility preservation in women of childbearing potential before they start nirogacestat. All right. So final slide. What is the summary of our whole program here? First, remember that this is a rare disease, and it's essential to refer the patient to a sarcoma center and integrate and get a treatment plan from a multidisciplinary group on what is the best approach for your patient. As I mentioned before, active surveillance is reasonable in a subset of carefully selected patients. If surgery needs to be considered, it is best done with a multidisciplinary group of medical oncologists and surgical oncologists and interventional radiologists before this is embarked upon. We talked about many different systemic therapies, such as chemotherapy, methotrexate, vinorelbine, pegylated doxorubicin, such as Doxil, tyrosine kinase inhibitors, particularly sorafenib at a lower dose, and of course the gamma secretase inhibitor, which is the only FDA-approved drug, nirogacestat, and some new gamma secretase inhibitors that are also being developed. Finally, nirogacestat is currently the only FDA-approved treatment for desmoid tumors. So lastly, thank you for joining and participating in this PeerView educational event on optimizing therapeutic control in desmoid tumors. I hope you found this discussion useful and informative for your practice. Thank you again.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from SpringWorks Therapeutics, Incorporated.